Hello everyone, welcome to 10-Minute Medicine. Today we're going to be speaking about how to manage low blood pressure. My name is Dr. Alia Sahni and I'm a foundation year trainee in the West Midlands. So how do we assess these patients? Well, a low blood pressure or hypotension is usually defined as a systolic of below 90 or a diastolic of below 60, but we heavily rely on systolic. So usually as soon as the systolic is under 90, even with a diastolic of over 60, we would still treat it as if it was hypotensive. Remember to always consider shock in any of these patients, especially with the low blood pressure, but if they're confused or less responsive, if they have reduced urine output or a new AKI, or if they have a raised lactate, you need to treat them as if they're in complete shock and not just simply treat the blood pressure. So what kind of symptoms do we see in these patients? Well, if it's someone who has low blood pressure but is not acutely unstable, they'll usually report things like nausea, fainting, blurred vision, dizziness, lack of concentration, and fatigue. Some patients just run a generally low blood pressure, and actually they could be quite clinically well even with a lower blood pressure. So what you can do is, if a patient is stable, you can look back at their previous blood pressures and see if the trend has been the same throughout, and if this is just something that's being flagged up by someone who doesn't know the patient, or actually if this is an acute drop in blood pressure and the blood pressure used to be previously quite high. So what are the causes of hypotension? So hypovolemia is the most common cause, and that's dehydration or actually losing fluid like a hemorrhage. There's also sepsis, like I mentioned before, like septic shock. Then drugs can cause that. So things like diuretics, beta blockers, things that we'd use to treat high blood pressure will always be causes of low blood pressure. And that's something to keep an eye out for, because sometimes it'll be, sometime in the afternoon where a nurse could come up to you and say, oh, I've noticed the blood pressure is low. Well, actually, they may have just given the beta blocker or just given their antihypertensive, and that's why it's low temporarily. And what you want in that situation is just to monitor it. Other causes could be cardiogenic, so patients with heart failure, patients in ACS, tamponade, dissection. Then you have more serious, obviously these are all serious things, including pulmonary embolus, pneumothorax. And so assessing for things like chest pain, shortness of breath, or pleuritic chest pain is very important. Then we have things like anaphylaxis. Obviously in an anaphylaxis, you treat as per the ALS protocol, and that you're aware of, that we will bring up in a later video. And then finally, one of the causes, of course, is vasovagal syncope, and that's just something that should resolve almost immediately, so you shouldn't be too concerned about it. So what are some red flags to keep a note of in hypotension? So chest pain, like I said before, ACS can cause hypotension, so it's very important to assess for chest pain. Breathlessness, again with the PE, the pneumothorax. Dizziness, palpitations, hemoptysis, because obviously that hemorrhage, this could be a variceal bleed, which is a very severe bleed. Throat swelling, if you're thinking about anaphylaxis, and even general bleeding. They could have PR bleeding, they could be bleeding from anywhere else in their body, or even internally bleeding. And so that's something to look out for as well. So investigations, what do we start with? Well, first things first, of course, I have this set up, but if the patient is unstable or hemodynamically unstable, you need to start with ABCDE. That is the most important thing. You need to do a complete ABCDE before we do any of these other investigations. Let's go through this as if the patient is currently hemodynamically stable. So you want to assess fluid balance. You want to do a full set of blood, so VBG for lactate, full blood count, U's and E's, CRP, troponin if they're reporting chest pain, D-dimer if they're breathless, and then also do a group and save just in case there's a hemorrhage, and then do blood cultures. You don't have to do the cultures, but of course in a patient like this, they may not be spiking a temperature, but could be in sepsis regardless. So it's worth always just taking that blood culture when you're doing a full set of bloods. Then you want to do an ECG, again, to assess for any ACS or any signs or any other concerns, and then a chest x-ray, because you want to see if there's any signs of infection, pulmonary edema, or anything else that we can see, or a pneumothorax, for example. And the next thing, then review the drug chart. So like I said before, of course, all antihypertensives can cause hypotension, so you want to review that drug chart. So the management, like I said before we do all those kind of regular investigations, we have to start with A, B, C, D, E and go through it. I'm not going to go into it in detail right now because we have we have another video on our website which details A, B, C, D, E and the process of going through it. So I definitely make sure to check that out. So you want to treat based on their symptoms though. So if they're in a hemorrhage, you want to be giving blood. If they're really losing a lot of blood, obviously you want to put out a major hemorrhage protocol. If they have chest pain, you want to be doing the ECG, troponin, start ACS protocol if it's appropriate, depending on the patient's history. But at that point, normally you do need to be calling for help. Then throat tightening, so obviously if it's anaphylaxis, and then dropped saturations, you want to be doing, consider a CTPA, do a D-dimer, listen to the chest, do a chest x-ray, because you want to figure out why are their saturations dropping along with their blood pressure. And the other thing you can do is you can tilt the patient in bed. So what you want to do, along with the fluid bolus that's just after, is you can slightly adjust the bed so that the patient's head is below his or her legs. And what that will allow is a natural version of a fluid bolus straight to the heart. And it should start to slowly push up that blood pressure. That won't work alone. So with that, you want to be giving small boluses of 250 to 500 mils. Remember that a can of Coke is about 330 mils. So actually, giving a 250 ml bolus, even if it's someone with heart failure, in someone who has very severe or even just general hypotension, is appropriate, and you shouldn't be as concerned about the overload, because a 250 ml stat dose is literally less than a can of Coca-Cola. Then oxygen, so if their sats are low and dropping, or they're unstable, you do want to give oxygen because you want to keep them in the appropriate range. Of course, if this is someone with COPD, make sure that range is adjusted. And then you want to repeat the blood pressure measurement. So as soon as that bolus goes through, you want to repeat that blood pressure measurement. If the patient is unstable, just keep that blood pressure measurement on a cycle so that it's consistently going again and again. So we can see as soon as it starts to improve. It's very important if if the patient is quite unstable and you don't feel like you can manage them by themselves, you want to call for help. If the one bolus or two boluses aren't working, you want to call for help. If you consider putting out a peri-arrest or asking for medical assistance, putting the call out, it means that you should be putting the call out, because it means that you do not feel like you have enough support around you. And it doesn't always have to be an emergency. Asking for help in that scenario is completely appropriate. Finally, like I said, escalating. So after you complete your ABCDE and you reassess, if the blood pressure is stabilized, then do hourly obs, have the nurses keep you updated, give them your bleep. If the blood pressure is not stabilized, of course, you rebolus them with fluid. So let's say in someone with heart failure, we're now giving them the second bag of 250. You want to contact, if it's out of hours, the registrar or the SHO as per your trust guidelines. Explain what you've done up till now, explain the bloods you've taken, the VBG results, and then explain what's the patient presenting as. Are they unstable? Are they stable? But there is a very detailed video about handover and SBAR that we have on the website as well, so check that out also. All right, everyone, that brings me to the end of this video. Thanks again for watching. Remember, if you have any questions, to email us or contact us on the website, our Facebook page, YouTube, or even Instagram. And we'll see you all later.